Today's guest is Dr. David Walton, physiotherapist, pain scientist, and associate professor in the School of Physical Therapy at Western University. Dave leads the Pain and Quality of Life Integrative Research Lab and has spent much of his career studying pain measurement, prognosis, and how clinicians make decisions in complex cases. He has received multiple recognitions for his research and mentorship, including the Early Career Researcher Award from the Canadian Pain Society, an Ontario Early Researcher Award, and the National Mentorship Award from the Canadian Physiotherapy Association. Dave has published extensively in musculoskeletal pain and rehabilitation and is the author of the book Musculoskeletal Pain: Assessment, Prediction, and Treatment. In this conversation, we dive into some bigger questions around the profession: what we measure in pain, why education still feels fragmented, whether specialization in physiotherapy actually makes sense, and what the future of learning and clinical reasoning might look like.
I think what I'm hearing people say is what separates the good from the exceptional are those additional those interpersonal skills, the ability to connect with people deeply and really listen. I will give you my truism. I will take this one to the grave. Nothing works for everyone, but everything will work for someone. Focus on those two things. I think, don't be afraid of engaging in some reflexivity and really look for opportunities to question almost everything you see.
Ladies and gentlemen, Dr. David Walton. Thanks for coming, Dave.
Hey, thanks for having me, Tom. Good to see you again. Appreciate the invitation.
I'm glad you can make it with your busy schedule. So I want to start off with, you sit at an interesting position between research, education, and the clinical world. From that vantage point, what trends in physiotherapy have caught your attention over the last few years?
Yeah, so actually, first of all, just for accuracy's sake, I should say that my lab group has changed names. We are now the CanSpine Research Group. The Pearl, as it used to be, has evolved, which is great. We're now CanSpine. But yeah, so you kind of alluded to it just off the top there. I think as far as trends that are catching my attention on the academic and sort of education side is the move towards sometimes specialized practice. So that was a big thrust of CPA, the Canadian Physiotherapy Association, maybe over the past decade or so. What I'm seeing now is a move towards something that is typically referred to as advanced practice, the advanced practice physiotherapist. And really both of those are about having physiotherapists fulfill sort of roles that tap into the full potential of their professional training, while also taking some of the burden off of other healthcare providers in Canada and trying to just depressurize the health system a little bit. So that's probably the biggest trend that I'm seeing right now. And I anticipate, we already have advanced practice physiotherapists in Canada. They're a little bit they're informal roles in a lot of places right now. I would anticipate within the next, I'll ballpark somewhere in the 2 to 5 year window, just to give myself a bit of flexibility in case someone goes back and listens to this in 4 years and is still not there. But yeah, that advanced practice physio will be a more formally recognized role, broadly speaking, within Canada. And you'll start to see physios sort of within like family health teams, within primary care clinics, really focusing on the MSK, the mobility side of intervention.
And is that going to be like a separate certification or licensing or something that kind of consolidates? We were kind of siloed into these specialty areas, and now it's kind of come the other direction into more, what sounds like more holistic, a more holistic approach. How are all those specialties now being integrated?
Yeah, so actually that's a good distinction that you just drew there. So where the specialist or the specialization, you can imagine sort of becoming deeply focused in a specific part of physiotherapy practice, where the advanced practice practitioner really ought to be able to practice sort of across many different sort of systems or settings. So you asked about, do we see that being a dedicated licensing or training pathway. And so I will say many of these things are still very much being worked out.
Gotcha.
The Canadian system is looking to other countries where something like the advanced practice physio is already well established, and the UK is a good target for that. And so there are some additional training pathways there, and you're starting to see those now crop up here in Canada. So an example, I'll be a bit of a homer on this one. So I'm at Western University, as you mentioned off the top. We have an advanced healthcare practice 1-year post-professional degree program. It's a master's level degree program, and those programs are structured around, allowing people to achieve what we anticipate to be the criteria for advanced practice physiotherapy as soon as it becomes formalized.
Does that then look like, so instead of going deep into one specialization and we're more broad, does it almost become like, I'm just going to use the analogy just for a better description, like a GP, right? They know a lot about, broad topics, but when somebody needs some kind of specialization or specialized treatment or something specific to them, do they become the point guard in which to, hey, you know what? We need to go deeper in this area, or you need a little bit more specialty. Do they become the quarterback to be like, start relegating or directing patients to those more specific specialists?
So yeah, I mean, I'm not entirely sure what sport you're getting at there, but as we know, point guards and quarterbacks often do
Sorry,
share
yeah, mixed
field
sports.
together.
Yeah.
I'm giving you a hard time. Uh, so I actually think that is an analogy that I could see playing out. So keep in
Right.
mind, we're sort of very much at the the evolution stage at this point. This is pretty early days having these conversations. You could imagine that an advanced practice physio, might be sort of like a GP in a way. So that might be one role that person fills. And I'm trying to be cautious to not paint all APPs with the same brush because again, there are some already in Canada and they do fulfill different roles. But you could imagine, as an example, you go into your family health clinic, and if you have a weird rash or the sniffles, you turn left to see your GP. If you have a mobility problem or maybe a MSK pain problem, you turn right to see your physio, your family physio kind of thing. And then that physio ought to be able to have the skills to be able to conduct a holistic diagnosis that will probably include things like imaging in the future if that's indicated and warranted, and that they'll have the knowledge to determine whether something like additional diagnostics are indicated. They should also know what other intervention options exist. So they might know that there's a specialist physiotherapist in pain management, in orthopedics, in pelvic health, in cardiorespiratory health, in the community, and they ought to know when the right time is to refer a patient to that specialist. So I could see that kind of arrangement happening. Again, it doesn't happen right now. At least if it does, it would be quite isolated pockets in Canada. But I think that's part of the conversation that's being had right now.
Yeah. What other questions about kind of the pain rehabilitation side of things in the profession might not be answered, or you said that it's another conversation. What conversations, what are we avoiding at this point in our junction of the profession
Oof.
that really stand out to you? I'm sure there's a
Yeah.
lot, but
Yeah, that's a big question. And I'm sure if you were to ask 20 different physios, you'd probably get 20 different answers on that one. But I'm the physio who's in front of you now, so I guess I get to give
I
you
want to know
my
you.
my perspective on that. I'm going to come at this from an academic perspective to respond to your question, acknowledging, as you said again off the top, that I do straddle some clinical as well as academic and education realms. Physio for years has positioned itself, rightfully so, as an evidence-based practice, as an evidence-based discipline, where we're starting to see some people sort of talking in otherwise language about this whole concept of evidence is coming right down to the ground level of what do we call physiotherapy evidence?
Right.
What level of research needs to be achieved to meet the threshold that the professional community would say that's acceptable evidence? For decades, in fact, we recently had the 100th anniversary of the Canadian Physio Association here in Canada. So we'll say for a century
Yeah.
or longer, physiotherapy has enjoyed a position sort of within the upper ranks of kind of the medical pantheon, the medical community, by virtue of adopting and endorsing the concept of evidence-based practice that you see common in medicine. Now, where in, let's say, a drug trial, it makes a lot of sense where you could do like a double-blind randomized controlled trial, for example, and you can give patient a pill, pill A, and patient B, pill B, and those pills could look exactly the same, but only one is active. And you could have a situation where even the person giving the pill doesn't know which one is active and which one's a placebo. Certainly the person taking the pill doesn't know which one's active and which one's a placebo. And depending on the health condition that's being explored, there could be very objective markers, indicators of success. It could be blood-based, could be imaging-based, whatever it might be. So from those perspectives, the idea of a randomized controlled trial makes a lot of sense. Physio has tried to, and to all due respect to those who have done some really strong, very well-designed, sort of pragmatic clinical trials, I think at least from my perspective, what I'm starting to see is that many physio interventions don't lend themselves well to being tested in a randomized double-blind controlled trial. And happy to talk about why that might be. For one, clearly, the interpersonal dynamic, for example, is an important part of physio that is often sort of tried to control out. One of the things where I do a lot of work in the idea of evaluation and measurement and trying to understand those things. I would say I'm not confident we've been measuring even the right things for a long time. Many of the tools that we use now that physios might be familiar with, they've been around for some of them, in some cases, 40 years. And they've kind of become entrenched. And yet, by today's standards, some of the questions that are asked on some of those legacy scales may not be as relevant today. Although it's hard to sort of dislodge them, right? So there's this we're going right down to the very basest kinds of questions of like, what is physiotherapy evidence and how strong does it need to be to then base a practice or a profession on it?
Right. Yeah, I mean, some of the metrics, the goniometers, the hand dynamometers, I look at them as measuring an output. But because of the complexity of the individual, if they slept poorly, if they ate the wrong thing, the nervous system can just kind of, I'm going to use quotes, and kind of locked up. I'll say, the nervous system's primary job is avoid threats and look for safety.
Right.
And if it doesn't like something that we're doing, it puts the brakes on, right? It protects and guards the individual, but that can also come from a belief. Some of the things when we say, well, manipulation works or dry needling works or whatever, but if the person had a bad experience with that in the past or a good experience, that's going to influence the outcomes. So it's really hard to use that model of the randomized control trials. It's looking at the psychosocial, the past history, the belief systems, the psychology of the individual, and then also looking at and understanding that the body can be different from one day to the next based on experiences from the day before. Like, it's so complicated.
Yeah.
And
it's highly complicated. And all the influences on someone's sense of wellness and health. I know when I teach our trainees, I will say something to the effect of, you might get to work with this client for, let's say, 20 or 30 minutes, depending on where you are.
Yeah.
What you do in that time certainly has an effect on their health, but the other 23 and a half hours of the day still very much have an influence on their health. And you don't always have a chance to control that, to address that. So you just got to keep that in mind.
And that's part of the, when clients are coming in, it's like, I'm with you for 30 minutes, but there's 10,002 minutes in a week. So what you do outside of that is going to have a far greater influence over what I just did for 30 minutes.
Right,
So
right.
I need you to do these things and pay attention so we keep moving in the right direction.
Yeah, I think about many of the questionnaires we use as well. That's another example. If we say we're treating something like pain, something like disability, functional impairments, even quality of life, these aren't sort of objective, concrete truths. I can't right now at least crack open your skull, take a look at the way the neurons are firing in your brain and say you are or you're not in pain, for example, and tell you how much pain you're in. So we're left really to ask the patient, or let's say the research participant, how they're feeling. And we will usually do that through standardized questionnaires. And there's another perfect example. Many of those questionnaires have been around since like the late 80s, maybe early 90s.
Yeah.
And they'll ask questions about, watching a television program, which by today's standards is different than what it meant, back in the 80s, or listening to a radio program. That's one of my favorite ones. Not sure many people do that so much anymore.
They're podcasts. They're called
Yeah,
podcasts.
yeah, maybe podcasts now. That's
Yeah.
what people should be listening to. But like even consumption of media, just using that as an example, has definitely changed over the past 40 years. I don't think anyone would argue that. And even in addition to that, there's questions like, can you walk a city block, for example? Can you go up and down stairs? They're sort of intuitively like urban centric. I remember, I traveled across the country about 8 years ago, and I talked to people all the way across Canada trying to better understand what mobility means. And people would raise those questions, and they would say things like, like I'd be going visiting some people on a native reserve or First Nations reserve, and they would say, look out the window here and tell me which one of these is a city block. I'm not sure how to answer that question. And just like examples like that we, even just the very nature of the thing that we think we're measuring, maybe it's time to rethink those or to challenge those a little bit.
Yeah. I mean, you coming from the pain specialization, what are we still misunderstanding about pain and measuring pain?
Well, I can tell you that far and away, and this will probably surprise no one, the most common way of measuring pain is asking someone to rate it on a 0 to 10 scale.
Yeah.
And it's, I don't even know what second place would be. Like, that is by far one of the most common outcome measures used in the world. And yet, patients, participants will frequently say it's really hard to do. And we assume that numbers hold similar meaning to everyone. And beyond the fact that you and I can both agree that 4 is bigger than 3 and less than 5, what 4 out of 10 pain means to you is very much different than what 4 out of 10 is going to mean to me.
Based on past experience and
Based
where
on
my
any number of
impression
things.
has
I
been.
mean,
You have to
think of
try.
all the things that influence your experiences of things like pain, wellness, or
Right.
health or whatever, and then say boil it down to a number from 0 to 10.
Right.
Like,
It's
that's
relative.
actually a lot harder than people might
Yeah.
realize.
It's relative to the individual because you get a young child coming in who's 9 or 10 years old who hasn't experienced that much pain. Oh,
Sure.
when I poke here, what's that? Oh, it's like a 9 out of 10. I
Yeah.
was like, yeah, but
Yeah.
you ran in here. And then you
Yeah.
ask
Yeah.
someone who lives in chronic pain, and they're like, oh, it's like a 2. It's nothing.
Exactly.
They're,
Yeah.
they're
Yeah.
limping and they can't move.
Yeah. So you asked sort of what are some of the unanswered questions? Like, yeah, it's exactly that. Like, what are we actually doing? What do those numbers tell us, for example? I think is an interesting unanswered question that we need to understand. Maybe we can use it to track change in the same person over time. Even then, you mentioned right off the hop here that people's bodies change, people's experiences change. Last night I slept really well. Today I'm really stressed about my finances. Tomorrow I'm looking forward to vacation. All of these things are going to change my experiences of pain, outside of my physiotherapy intervention. And so just keeping that sort of in mind, it's not to say we have no effect. I don't think that's true. I wouldn't keep getting out of bed every morning if I thought that was true. And yet we need to probably temper our expectations of effect in light of those 10,000 and whatever, I think you say 10,002 other minutes in the week, which I'm trusting you on that. I haven't done the math, but
I
I
did
feel
the
like you
math.
have.
I did do the multiplication. It's 10,000 and a small number at the end. I know I'm
All
close.
right.
If it
Well,
was if it was jelly beans in a jar, I would win. Let's just put
you'd
it
get
that
it.
way.
Understood.
Yeah,
All
yeah,
right.
yeah.
I'll trust you on that. Yeah. So yeah, I think even just understanding like this whole question of what we think we are meant to be changing with our treatment.
Yeah.
Are we meant to be changing a number from 0 to 10, which again is overwhelmingly how the majority of clinical pain treatment research is done. That's the number one primary outcome is 0 to 10 pain
Yeah.
scale.
Yeah.
Is that what our interventions are meant to accomplish? If they are, I can tell you the best way to change a number from a pain score from a high number to a low number is lots of opioids.
Yeah.
That would probably reduce your number pretty well. Is that considered a good outcome? Is a really important question. And yet, the majority of our treatment guidelines are all based on research for which, the primary outcome was a change in 0 to 10 scale. And those are
What
important questions for us to have, or conversations for us to have.
what are your top three? So if you're in the clinic, what are kind of the three top outcomes that you look for?
Narrative, number
Or,
one.
of course, yeah, yeah,
Yeah,
yeah,
yeah, absolutely. So that's part of where sort of I'm, my my academic program is going these days is how, in what ways can narrative be used and integrated into research. Yeah, clinicians are so good at this. Clinicians intuitively use narrative. I ask them what is a good outcome to you, and invariably one of the answers will be whatever the patient says it is.
Yeah.
And
Whatever
that's
you-
about as patient-centric as you can get, but try and do research on that.
Right.
It's a nightmare, right? I do believe that and I don't yet know what this looks like. I believe the increasing accessibility of large language models and their ability to sort of parse narrative and language into meaningful parts. I believe there's a potential there for changing the way we do research, where now narrative can actually be used as a research outcome at scale. Because prior to this, it's been that narrative has been sort of relegated to the domain of qualitative research, which is great. I love qualitative research, and it's really hard to do at scale.
Yeah.
So that's why most qualitative studies are 8, 10 people. Now, I actually do believe that, the chat GPTs or whatever of the world will be those that allow us to take narrative and then, like I say, turn it into some kind of a
Large scale.
a unit that we can use in research. So to answer your question, yeah, narrative for sure.
Yeah.
And then, I've got some tools that I've created that I quite like. So one of my favorite ones is called the Multidimensional Symptom Index. And I should say I'm not selling anything; they're all for free. I can link to them if you want afterwards. But that's a tool that anyone can use, can access, and it explores symptom experiences across 10 different symptoms, both in terms of the frequency of experience as well as the magnitude of interference. And frequency is something that we don't very often ask about in clinic. We'll often ask about, the magnitude or intensity of the symptom. We don't very often ask about the frequency. So that was something that patients told me years ago when I was starting to build this scale. They said, ask about the frequency. So that tool, the Multidimensional Symptom Index, that captures both in the same scale. Yeah, I think I probably addressed it in the book, but now we've got like a little free web app that people can access to if they want to use that.
Oh, perfect.
But one of the nice things, what I like about that is you've probably heard me talk about radar plots and things like that in the past, is it kind of plots symptom experiences on like a radar plot, and it helps point clinicians directly to sort of the primary symptom areas or symptom problems that these patients need help with. So I think like a good tool, that's what a good tool should be doing, is it should support your clinical decision making. It should make your assessments and evaluations more efficient, but it shouldn't dictate what needs to be done, right? That's, again, where the narrative and where the partnership between patient and clinician really comes in.
What, in your opinion, what do you feel predicts recovery in MSK pain, musculoskeletal pain?
So I'll go beyond opinion. I can say as someone who's done the research many times over, I can tell you that far and away it's things that fall within the psychological domain.
Yeah.
So first of all, I'll say the best predictor of any outcome is always the same outcome at baseline. So I'll start by saying that. So one of the best predictors of like pain intensity 6 months from now is pain intensity right now. One of the best predictors of work status 6 months from now is whether the person's at work right now. And that's just statistically and just common sense. Those things make sense. Right. But when we look broader than that and we look across, right now we look at physical biomarkers. So I've looked at biomarkers of distress, so things like cortisol and inflammatory markers and things like that, even genetic markers. When we look at psychological state, thoughts and beliefs about pain, and when we look at social determinants, and I've looked across all of those, and consistently the ones that are the strongest predictors of either a non-recovery after an acute injury or a poor response to rehab in chronic pain tend to be those more psychological things. So depression, as an example, is one that consistently comes out as strong. And then I'll plug another tool, again, another free tool, the Traumatic Injuries Distress Scale, which is another one that I've created. And that is a risk and prognosis screening tool meant for people with acute injuries. And it has shown consistently strong ability, especially to identify those who are likely to recover well.
Mm.
And that's what a lot of these tools are best at doing. A lot of these tools are really good at identifying those who probably don't need a whole lot of intervention because they're
Right.
going to recover, maybe even in spite of what you do at
Right.
times. They're going to do okay. And so that's where I see the value of these kinds of risk and prognosis, like things that you were just
Yeah.
talking about, is identify those who probably don't need a whole lot of intervention. Maybe would be best just sort of with some arm's length, advice and education.
Yep.
We'll follow up in 2 weeks to make sure things are going well. And what that does then is it frees up your resources for those who maybe do need a little bit more involved care.
Yeah.
And that's the TIDS, again, is based in the name. It's a distress scale. So again, one that taps the psychological domain.
Now, what about for the ones who don't score well on the TIDS? And what's your strategy around that then?
Yeah. So that's actually that scale was designed to also include a little bit of guidance for clinicians. So there's actually three sort of sub scores that you can pull out of that. And again, there's a web app, and I'm actually working just before today. In fact, I was working on improving that. If for those who score, we'll say above the threshold, the risk threshold, and who at least are unlikely to recover easily, then it also gives scores on negative affect. So is this an issue of, a sort of, again, early signs of depression, for example?
Yeah.
It gives a score on poorly controlled pain. So that would be a good direction to face if somebody scores really high and says they have a hard time controlling their pain.
Yep.
And it gives a score on what's called intrusion or hyperarousal. So intrusive thoughts, so kind of precursors to kind of like a post-traumatic stress.
Ruminating.
Exactly. Yeah. And so it gives a good score on each of those three domains. So at least that starts to point clinicians in a direction that they can then continue to do their workup. Again, I will say you should never make a decision about a patient based simply on numbers circled on a form, but it gives you a direction to then continue on and say, hey, I see you've indicated these things on your form. Can you tell me more about that? Is that accurate? What's going on, and let's carry on with the conversation from there. One other thing that we've just started doing is I mentioned that radar plot concept sort of earlier, and the different sort of axes or domains of pain drivers. I would say for years I've kind of resisted trying to make that an algorithm and quantify it. I've kind of preferred to leave it a little bit more qualitative and narrative. But I've been pushed hard enough that we do have now some algorithms that will help people sort of identify the dominant pain drivers as well. So we started with that in military veterans with chronic pain.
Yep.
We've just submitted a follow-up paper, which is in acutely injured workers. And in both cases, we can identify sort of somewhere around 4 or 5 kind of profiles of pain. So an example, there's one profile that aren't really all that affected. Again, that's the group that you probably just take a bit of a hands-off approach, let nature take its course, that kind of thing. There's a group that is dominated by high mood or psychological interference. There's a group that's dominated by high neurological, like neurosymptoms, sensory motor incongruence, that kind of thing. And then there's a final group that's kind of complex, like kind of scores high across the board. And so we now have the algorithms, and we published the one for veterans. We just submitted just a couple of days ago. I submitted the one for injured workers. And like I said, that we're trying to put this all into some kind of web-based application so that people can use it easily. So that'll be coming down the pike.
Yeah, I find algorithms helpful, as at least especially as a younger clinician, trying to piece it all together. At least it's some form of a roadmap to follow.
Mm-hmm.
But then obviously you use clinical reasoning when you get to these certain forks in the road. Just like you said, you have those 5 different presentations. You go through the general algorithm, they get to this fork, and then you're like, oh, you're kind of diverging over here. But then it goes into another algorithm. I mean, everything's an algorithm. Surgeons follow an algorithm. It's a certain process and system of step by step. And it's helpful, especially early on. And even as a more seasoned clinician, I go through an algorithm with every assessment. But then you hit a point where you're like, okay, I can use my critical thinking here. I can start to think outside the box.
And I never want to see the clinician come out of that loop there. Sorry, Tom. And I will say this, what's really good at algorithms? Computers and AI are really good. And so if everything we did
Sure.
could be boiled down to algorithms.
Yeah.
You don't need the clinician anymore. So
True.
I completely agree with you. The algorithm helps, again, it gives me a head start. It helps
Yes.
direct me, like I use the example of a compass, it kind of helps point me in a good direction to go. But then I need to be the human in the loop. I need to use not only my critical thinking, my clinical reasoning, but also my interpersonal skills
Of course.
and form that rapport and then try to develop that partnership. One of the things I always will say is that um, if I approach every clinical interaction as saying, I've got a sphere of expertise, I'm a trained physio and I understand things about the body and biomechanics and things like that. You, as a patient, have a sphere of expertise. You're the expert on what it is to live in your body, your lived experience. You're the expert in that. Where those two things overlap is, I think, where the magic happens.
Yes.
So I can bring some of the algorithms, I can bring some of that, evidence stuff. I can bring that in, and then I need your experiences. I need your lived experience. I need your perspectives, and we need to come together and mesh those things. And
For sure.
I mean, that's
And
true person-centered care.
I want to take a quick break from today's episode to share something I believe every rehab and performance professional should know about. For years, I saw too many clients go through the same cycle: short-term fixes, temporary relief, and then the same issues coming back again. That's why I built the Advanced Movement Therapist certification. It's not just another course, it's a system that helps you identify the real cause of a client's pain, give them results that actually last, and stand out in a crowded industry. You'll get practical tools and strategies that you can take straight into your sessions so you can help people get better faster. If you're ready to become the go-to clinician in your community, head to amtcertified.ca to learn more. That's amtcertified.ca. Your clients will thank you. Absolutely. And bringing that human experience into the logical
Yeah.
side of what we do is so critical, because you can be the most technically sound clinician and have the best techniques and be really great, but if you can't connect with that person, they don't like you, or they don't like being with you, nothing's going to change really. Like
Yeah. Yeah.
that human experience and those, we'll call them soft skills, are the other side of the coin. Like, you got to be a
Yeah.
technician, but you also got to be a human at this as well and show
Yeah.
that empathy. Do you think, physio spends a lot of time on kind of technique and education? Do you think we underinvest in the teaching the clinical reasoning, empathy side of things?
I think that's changing.
Yeah.
I do think that's changing. So again, I can give that perspective from me as an educator now, I guess. I will say, having now engaged and been around tables with different curriculum groups and having conversations just with colleagues at different institutions, I'm really impressed by what I'm seeing happen in physio programs. I don't think it's mission accomplished. There's still lots of room to grow, of course. One of the examples that I'm seeing a lot more of now is, again, patient partners coming in as educators. And that's something that certainly I didn't have the opportunity to experience when I went through my physio education. I had the expert talking heads up on the stage kind of telling me what I ought and ought not to be doing. What I'm hearing now and what I'm seeing even in our own program is we've got people who live, let's say, in a painful body, come in, and now they're the teachers to all of these future physiotherapists, and they're telling them, here's what I need from you when I come and see you in the clinic. And a large part of that is that empathic approach, and it is that an element of let's call it epistemic humility, I guess, for lack of a better term here, to say that I can bring my knowledge for sure as a clinician, I can bring but I don't know everything, and I don't know what it is to be in your world, to live in your body. And so, it's almost that let me start by listening part. Let me hear your narrative, and then let me see if I can make sense of it based, from the context of my own knowledge. And there's a little bit of a dance you enter into, and a little bit of sometimes a push and pull, occasionally a bit of tension that hopefully you can sort of roll with. Inevitably, though, you keep working through it, and you get to that point where you found an intervention direction, a strategy that works for this patient and aligns with what you know about health and the body and that sort of thing. And I do see that, like I said, I do see that coming in more into PT education programs. Again, not perfect,
Yeah.
I'm not trying to claim we're perfect, but that's definitely a shift I've seen over the past 5 to 7 years.
With that new perspective coming in and having the clients or the patients come in to bring in that perspective, do you feel as though that clinicians will come out stronger out of school and start to look at that side of things?
I mean,
Or
you hope so. I think
we
that's the
don't know yet?
vision.
Yeah.
Yeah, well, and that's just it. Like, how do we know if our education is effective is a really interesting question. Uh, it's a question we continue to have.
Yeah.
Well, they didn't end up in front of the disciplinary body of the regulatory college. I guess that's great, but that's a very fair, like a very small number of clinicians every year end up there. So that's not really a great indicator.
No.
Similarly, they might say, well, they've passed the licensing exam. Well, again, great, but 95 to 97% of people pass the licensing exam. That's also not a terrific indicator. So this question of sort of like really what makes a good physio, that is something that has been on my mind for many years. And actually, I'll acknowledge one of my former PhD students, Michelle Kleiner, who her whole thesis was on exactly that question: what is a good physiotherapist? And I will say, to the point that you, I think, were making earlier, anytime I ask that question of clinicians, and it actually doesn't matter about physios, if I ask it of chiros and massage therapists, physicians, nurses, and the responses are remarkably consistent. If I break down the responses I get, about 20% of the sort of pie relates to technical skills, good hands, whatever, strong diagnostician, that kind of thing. And about 80% of those really do fall within, you call them soft skills. I don't even call them essential skills, that sort of,
Yeah. We'll call them
yeah,
human skills.
interpersonal domains,
Yeah.
communication, empathy, compassion, presence, that sort of thing. Like, and so my interpretation of that is that everyone expects your clinician to be competent. Like, frankly, nobody cares how nice you are if you're not competent. So we expect a certain level of competence, but I think what I'm hearing people say is what separates the good from the exceptional are those additional ability, those interpersonal skills, the ability to connect with people deeply and really listen.
Are you seeing maybe the pendulum might be swinging too far that side? Because I've seen some patients and some clinicians where they come out of school and they're like they don't have any technical skills, right? They didn't
Mm-hmm.
do any additional courses, kneeling and all those things, and they're talking to people more than actually touching. And I'm like,
Right.
you still need that physical like you still need to make contact. You still need to move stuff around. You still need to add exercise. But the research says, it doesn't matter. Yeah, but you're not a psychologist. It's like they've negated away from the importance of physical touch on the nervous system and the overall
Yeah.
treatment experience. And they talk to them and they give them some random exercise. I'm like, how do you even know those exercises are going to work? You haven't measured anything. And are you seeing that at all?
Yeah.
Because
Oh,
that's my
you
fear.
just touched on a whole lot of really important things. We could
Well,
we could
let's go into
unpack
that
each
a
of
little
them.
bit.
So I mean, yeah, like, so first of all, you mentioned the research says. Well, as you and I were just talking about not 15 minutes ago,
Right.
I would be cautious about basing your entire professional approach on the research. And I say that as a researcher, as someone who is apparently one of the top 5 researchers in neck pain in the world, apparently. That I would, well, I say all that means is that I'm more aware than most of what we don't know,
Yeah.
really. And so, I would be cautious in saying what, the research does or doesn't say this.
Mhm.
I will give you my truism. I will take this one to the grave. Nothing works for everyone, but everything will work for someone. And I do believe that your role as a clinician is to figure out what this person in front of you needs right now.
Yeah.
So I do think that's true. You talked about the idea of the technical skills and the hands-on, and keep in mind, I'm someone who went through the manual therapy training program in Canada. I got my FCAMPS designation, and I'm very proud of that. And I was mentored by some of the best, and I continue to believe that physical contact and touch is a really powerful communication pathway. Um, do I believe I can necessarily tell whether C56 on the right is moving 2 millimeters less than it is on the left in a superior anterolateral direction? Not really. I don't know that I can do that. But can I give the patient the sense of confidence in my hands and my handling? Can I grossly feel whether there's, like, when I do this, does it hurt? I mean, still think that's valuable information to have. Can I draw your attention to a part of your body that perhaps you've been sort of neglecting for a while by virtue of my confidence, soft but confidence hands, we'll say? I hope so. And I do believe that there is definitely value in making contact with people. And it's one of the actual privileges, I would say, that we as physiotherapists get that not a lot of other health professionals get. Our ability to put our hands on other people it's a privilege, and it's a powerful privilege that we shouldn't take lightly. Where I do think the change has occurred, and I think maybe partly what you're getting at is, as you're probably well aware, that there has been a shift in thinking about manual therapy from when I started. So I graduated in '99, so I don't know, what is that, 27 years or so? When I started going through that process, very much the focus was hands here, feet here, position like this, patient in this. There's only one way to do this, and you do this right. And if you can't feel this, you're somehow less than, kind of thing. Like, it was highly focused on the specifics. And again, at the time, that was the thinking. Like, I'm not trying to criticize anyone. Like I said, I had outstanding mentors. That was the thinking at the time. That thinking has clearly shifted. And even within, I mentioned the advanced healthcare practice programs we have at Western. One of them is in comprehensive musculoskeletal physiotherapy. That is the manual therapy program. We'll say people come out of that program with both a master's degree and an FCAMP designation.
Yes.
And even there, you can see now that focus on specificity has definitely softened. There's some things you still need to know if you're stressing an ACL or not. Like, there are certain things that you still do expect. But yeah, that hyper specific focus has shifted now more to the sort of, what does this patient need right now? But there's still very much, your hands still remain an important communication pathway, just as much as your voice and your ears and your eyes do.
Yeah, it's, coming back, going through the FCAMP myself, and I love having the skill set, and it gave me a better understanding of, and developing that sense of touch, of how much pressure to use, how much do I need to actually elicit a positive change. Because, as we all know, new grads, we come out and we're poking and we're digging and the hands are hard, and but it is that form of communication to know with the nervous system. I always look at it from the lens of the nervous system, whether it's letting me in or not. If someone's toning, their breathing's changed, okay, I might be in the wrong area. I might be treating something at the wrong time. So let's take a step back and see what they actually need. But it's like they don't want to take, or they don't feel like they need to take the courses. So for students graduating, where do they feel the biggest gap is? You're still doing, well, I guess, your consolidation. I think it's called something different now, at the end of the 2 years. Where's that gap still between theory and real practice?
Yeah.
Especially at placements.
So I bang on. Actually, one of the activities I have our students do, and I manage one of the final courses in our entire program, is I have them sort of set their own personal 2 and 5 year strat plans, and set their own kind of personal vision and mission statements, and kind of get themselves hopefully on the right path. And part of that is, thinking about continuing professional development. What might you focus on? Interestingly, I will still say overwhelmingly the number one that I see is dry needling. Whatever that's worth, that's still the number one. Another one that I'm seeing a lot more of, and I can certainly appreciate this, is business skills, business acumen. Yeah. I think people, I'm not sure that everyone coming into physio realizes just how much, free market capitalism kind of influences, physiotherapy care, but still, I think I can't remember the stat right now. I want to say 70% or so of Canadian physiotherapists will work in the private sector, and will work in a private, outpatient clinic, for example. Yeah. And you need to know the ins and outs of that. I will say that is something I've traditionally been terrible at. I have actually been literally called the world's worst self-marketer, self-promoter. I know I'm awful at that. Yeah. And I don't know what that is. Yeah, I don't know. Misplaced humility, perhaps.
I was going to say, it's part of your Canadianism. It's just like,
it must be. Yeah, that's right. Yeah, that's
humble. We don't need to boast.
Yeah, sure. The Canadian coming through. But that's I think, and I do think that especially young clinicians, they get out and they quickly realize that a big part of their practice actually has to do with the business side of that. And while we do kind of have some like, I think we have one, not even a business course, it's like a part of a course now where they kind of have that conversation, but it's not a strong component. So
No.
that's something that if the profession is going to continue to move in this direction, which I see by all indications it is, that might be something that we probably need to get a little bit better at.
Yeah,
Not so much a
absolutely.
clinical skill, but still a skill of being a clinician.
Yeah, well, it's another form of metrics to know if we're doing the right things and the patients are into the treatment plan or they believe in it, they won't fall off. If they're
Right.
falling off, so we use metrics and we track that, but it's always on the case of best practice of what's the best for the patient. How many times do you need to see them? Well, it depends on tissue adaptation and the injury. Okay, well, that's going to determine how many times per week or how long. And of course, we're doing reassessments regularly, if
Hmm.
not every single time. But it gives us an indication of, okay, well, the patient fell off after the first appointment. Was it lack of clarity, lack of
Right.
expectation, right? Like, so
Right.
now maybe, okay, maybe they just couldn't book their appointments because their child was sick and they forgot. So, well, let's give them a call.
Sure.
Hey, you're still in pain. Come on back.
Yeah.
We know from the stats we've collected over 14 years of doing this, 8 to 12 is kind of that magic window of where people are 100%, right? Not just
Mm.
4 appointments. Yeah, you got rid of their pain, great. But can they load that shoulder? Are they throwing again? Are they back to sport? Well, we need to load and recondition the tissues because that was lost. If we just get rid of their pain and then all of a sudden they throw a ball, now they've done something worse. We didn't help them in the long run. So, but it's business and it's also case management. It's also doing the best thing
Yeah.
for the patient because we want them 100%. We don't want them back for the same injury or long term. That's not the plan. And once they understand that you're in a service industry and you are in sales, but you're in sales because you're educating the patient and they're coming to you with a problem. So they want you to help them with their problem, but we have to educate them and let them know, hey, here's the plan, here's what we need to do together because this is a joint relationship so that we can get you out of here as fast as possible. But even just that, every clinician's work, they're doing a business inside of a business. They don't have to know the
Mhm.
outer workings of the business unless you want to run a clinic, which is a whole
Right.
other monster. And it's
Right.
actually, but at least know your business. And people can, and then clinicians can do that. You can grow a brand, you can do all that stuff inside of it.
Well, you're
I
kind of
think
taking
that,
like a QI mindset there, I think a quality improvement sort of mindset. And I think
yeah,
that's a
it's
good
quality
mindset to
improvement.
have.
Yeah.
Your comment there about how do you know if you're being effective if you're not measuring anything, I would say that resonates. So again, as a measurement scientist for sure, I can
Yeah.
understand the value of that, of course. But I will also say like so one of the things I will do is I'll occasionally provide the occasional expert opinion on sort of malpractice claims involving physios, and it's remarkable how often I'll see in those. I'm not saying this is the nature of the claim, but that there really hasn't been a whole lot of reassessment, and it's really hard if I'm looking at a file and I'm trying to do like if I'm asked trying to answer the question, was the intervention indicated?
Right.
If there's no anything, there's really no reassessment. It's really hard to answer that question. So yeah, I agree with you that it's all sort of that QI. Am I delivering a quality product? That sort
Yeah.
of mindset probably needs to permeate the profession a little bit more than it really is.
Yeah. It makes it, I find school, because they put the fear of God in us
Mm.
of all, with these cases. But at the same
Yeah.
time,
Yeah.
where clinicians are coming out of school, well, I'll see you once in 2 weeks. They've got a sprained ankle. Like,
Hmm.
what change is happening? We're doing a disservice on that end because we're not helping them when they need our help. But then you have the
Hmm.
other side of things where the regular assessments aren't happening, and yeah, they're here too long. What do they need this anymore? So
Yeah,
the
absolutely.
fear has been put in us in the
Yeah.
new grads of like, oh, I'll see you once a week. I'm like, okay, again, 10,000 minutes in the 30 minutes, how much change are we making?
Yeah, and I just, and I will admit I struggle with it too. I think it's
Yeah,
not easy for a lot of young physios to feel as though they're sort of in sales, but
sure.
you kind of are. Like it's
You kind of are.
kind of the gig. And maybe just maybe the pro or maybe the educational programs aren't adequately preparing
Mm.
students for that way of thinking.
Coming back to kind of the specialization in physio, is there is it necessary for the profession to evolve into still some specialization, or do you feel like we might do a better job with the advanced practice,
Yeah,
or
well,
we don't know yet. Too early to know.
yeah, well, I mean, yeah, I could take the cop out answer and say we don't know yet. And that is true. It's, interestingly, this is a historical lesson I remember learning from some aspect of history, and it had to do with the dinosaurs. And it was, and I'm going to paraphrase it. It was something to the effect of the dinosaurs that survived were the generalists. The ones that went extinct were the specialists, right? So as soon as that one thing they eat, and maybe they eat it really well, or that one thing they hunt and they're the best at hunting it, as soon as that thing's gone, the
Right.
specialists are vulnerable.
Right.
So I actually think it kind of resonates actually.
Sure.
Whereas the generalists who can kind of, they could forage on any number of things or hunt any number of things or live anywhere, those are the ones that survived. And I do think there's an element of truth as well in healthcare. I kind of think we need both. If you were to really press me, I do think there's value in having the occasional specialist, but just like not every medical clinic needs an orthopedic surgeon or a neurosurgeon or whatever. Like a couple in a community will suffice. I anticipate that's the kind of level we'll get to in physio as well, with the advanced practice physio now being almost like the GP gatekeeper in a way, who can still do some intervention, of course. They're still skilled interventionists, but then know that actually, you'd be better off with that specialist down the road. So I'm going to make a referral there. So I think the answer is going to probably, well, hold on, I take that back. Ideally, it would be both. Again, there are forces that are bigger than either you or I or the universities that will be at play here, or the professional associations, and that really are just the broad political will, the will of the population. Is there a will to pay for advanced practice physio? Is there a will to pay for specialist physio? I think that's where it will be incumbent on us, or the people who fill those roles, to demonstrate the value. And again, I think we're a ways from that yet. But once again, we can look at other countries who have already implemented these models and are seeing value there. So I don't think it's as far away as we think, but there is still there's some hills to climb yet.
Do you think continuing education in healthcare is moving away from the universities?
I don't know, is it? Yeah. It probably
Even
is.
specialization,
Yeah. I mean, I could say one thing that I know, and this is going to make me sound so much like a Gen Xer, but I know so many of our young people are learning a lot through the social media platforms. And that kind of like just in time learning, that sort of brief, snippets of advice or information, it does seem to resonate. And so I almost see that continuing professional development. The universities have never been fully engaged in CPD. They've sort of done a lot more of the entry level education and then left the CPD to the outside providers. I see that shifting where, like, again, when you and I graduated, the idea of the weekend workshop and the weekend course is just what you did. I mean, I knew people
Yeah.
who went to courses, it
No.
felt like every other weekend, right? Like, I mean, absolutely. I feel like the appetite for those is shifting to now more, maybe more mentorship, more like online things, more of these sort of brief kind of hit me with something really interesting and then I want to go and try it out. So I do think that just the broad appetite for CPD is the way people want to take that information is shifting. Yeah.
The one problem I see with that is people get a snippet online and they don't get the
Yeah.
understanding of why it was applied, how it was applied. There's like, oh, I saw a result. I should try that. But you
Right.
do not know how they got there. You saw the end result
Yeah.
and you're coming up with an idea of when it should be applied, but it's a very superficial understanding. And
Yeah.
they might do, you give a monkey a gun and the monkey shoots somebody, you don't blame the monkey. But they it's not, I don't see it being a positive then. I think it gives people more interest, but I don't know how many people are actually looking for the deeper understanding when they see those things. Is
Yeah.
that,
I think you're right. I was going to let you run with that monkey with a gun analogy to see how far you took it.
well, I've seen some patients where they got shot by a monkey because the monkey stuck a needle in a place that they shouldn't have because it was tight, and
Understood.
they
Understood.
removed some protection over that area and they didn't assess it
I,
properly.
I do believe,
Yeah.
and this is maybe a good place for us to actually wrap up, that
Yeah.
there's going to be the two critical skills or competencies for people to develop for the 21st century. One of them is reflexivity, It's knowing what you don't know, understanding your own biases, and understanding why you approach things the way you do. So reflexivity is one, and critical thinking is the other. Especially now in a world where I could go to, again, an AI tool and within 30 seconds create something that sounds really convincing, looks really good, looks highly polished, even a video, stick it out on the web and get lots of, like, people are going to need to know, like, that's just going to become more and more prevalent. And we need to know how to distinguish between the good and the not good information. And that has become so critical in my mind. So if I can leave your listeners with anything there, it would be really focus on those two things. I think, don't be afraid of engaging in some reflexivity, and really look for opportunities to question almost everything you see. And boy, that sounds like a researcher thing to say, and maybe it is, but I also believe it's true. Yeah. We need to question now everything. Nothing can be taken at face value. So of course I'm going to see the best outcome of some influencer who did something on social media, or of course I'm going to hear somebody say, do this and it will cure your back pain or your neck pain or whatever. I mean, that's always been the case, but now it's more prevalent because it can be created so quickly and it can circulate so quickly. We as health professionals have a responsibility to do our homework and make sure that what we're hearing is actually true and relevant. And that's a critical competence in my mind.
I love it. That's a perfect ending. Well, for those of you who don't know, Dave was one of my professors at Western, and we've become
I do apologize to your
patients. I am a direct product of Dave. There we go. Dave, I appreciate you. I appreciate our friendship, everything you've done, everything you've taught me. Where can people find you?
Yeah, if I want to be found, I will say partly based on what I just said, I have moved a bit off of the socials over the past few years.
That's all good.
Yeah, no, very much. I'm actually always happy to receive emails. My bio or my contact information is not hard to find. If people go to uwo.ca, my contact information is all there. I'm very happy to have people reach out to me. You can still find me on LinkedIn as well. I'm still there, but I've taken a little bit of a step back from the other socials.
All good, buddy.
All right.
I appreciate you. We'll talk soon. Thanks, Dave.
Thanks, Tom. Take care.
Thanks for listening to this episode of Staying Relevant. If you enjoyed it, check out the AMT certification at amtcertified.ca, where we help clinicians and coaches get better results faster. Don't forget to subscribe for more episodes and share this with a coach, clinician, or athlete who needs to hear it. Until next time, keep learning, keep growing, and keep staying relevant.